one more person. And then if you'd like to share the first slide. So welcome everyone, a really warm welcome to you all. This is an opportunity to hear from members of Oxfordshire, Buckinghamshire and Berkshire West Integrated Care Board about the development and process of the primary care strategy, and to have your say and comment on that strategy. So we're really pleased to welcome today Dan Leveson, Place Lead for Oxfordshire, Louise Smith, Deputy Director of Primary Care for the Integrated Care Board, and Rachael Jeacock, Senior Primary Care Manager. So today they're going to give a short presentation about the primary care strategy, and then at the end we'll take questions, and you can have your comments and say what you'd like there. Please do put your comments in the chat. But remember, this is a public session, so try not to share personal information would be helpful. If you could all make sure you're on mute as well. So very much welcome, and we will start the session.
If we could go on to the next slide, please, Alice. Lovely. All right, so good evening, everyone. My name's Louise Smith, as Veronica has mentioned, and I am the Deputy Director for Primary Care across BOB. I hope you've had a chance to have a quick look through the primary care strategy. I'm going to take you through it this evening, but really what we want to do is have an opportunity for any questions or queries from the public, and hopefully it should be straightforward. And there's still an opportunity to feedback formally into our engagement portal and that email address, which won't close until the 29th of February, which actually is tomorrow. So there is only 24 hours now. So the primary care strategy, why did we need a primary care strategy? So it genuinely came from a good place. We recognise in BOB primary care being one of our most essential providers, if not the essential provider, and that includes not just general practice, but community pharmacy, optometry and dental. And this strategy encompasses all of those areas, which we call the 4 pillars of primary care. Our services in BOB are of very good quality, both in clinical outcomes and in access, although sometimes it might not feel like that. What we do have is variation, and that's quite normal, but we do need to address that variation, and particularly any outcomes in inequalities that would come as a consequence. We also have some workforce gaps that we acknowledge, and specifically high workload. So we're keen to look both locally but also at what's happening nationally. So nationally, we know that access remains an issue, but we've got several key papers that talk about new concepts like integrated neighbourhood teams, and this strategy tries to provide a vision in the context of our local and national expectations. So if we go to the next slide. So this is what I call our happy slide. It's the bits in primary care that really are going well. I've already mentioned access and some of that quality aspect, but we have really innovative and engaged providers here. So our pharmacy colleagues are keen to be involved in the new pharmacy consultation service, which is kind of morphed into pharmacy first, which you might have heard about on the news. We do try to focus on our inequalities and our prevention agenda, looking at those pockets of deprivation and the wider determinants of health. And we have tools to help us do that. So we look at what we call population health management, which is using the data that informs us of the health needs and social needs of our population. And we use that to proactively care for our patients. As I've mentioned previously, we're quite innovative here in Bob, and we're doing things like we call flexible dental commissioning, which is using the commissioning tool a little more flexibly so that we can focus on our most vulnerable patients and really try and deliver more care for those vulnerable populations. And then we have a lot of providers that do function well at scale. So you might not feel that way. Sometimes we have general practice that operates as a business, standalone business, but actually they do also work in PCNs and sometimes work in what we call federations, and they're really strong here in Bob. So that's a real positive for us. If we go on to the next slide, and this demonstrates a bit more the things that we're doing or why we're doing the strategy in a little bit more detail. So this is just highlights that worsening experience of primary care. So we do have things like friends and family. We do have a general practice survey that comes out every year, and we do see a decline in the positive responses. Those responses, really, we have to be careful when we look at them. Sometimes those responses are according to people's preference for how they access services. So but what we do know is generally there's a decline in that satisfaction. Our staff are the most important part of our service, and the information that we've collected, particularly from our local LMC, suggests that they're feeling quite under pressure currently, and that's for a number of reasons. And whether that's because of the nature of the work coming through, the volume and the hours. So we need to think about how we might address that. And that's not just general practice, that is dental colleagues as well are highlighting that. Often in the NHS, we talk about something called demand and capacity. So what this really means is that demand from our patients, so that need for our patients to be seen, is rising, and what we don't have necessarily is that capacity, so that service to meet that need. And that's an element that we need to address, and that's because of the different the growing population that we have. I know that there's a lot of new builds in various different places across Bob, and that just generally means that the population is growing and people are living for longer with different conditions. So that demand really is scaling upward. And the capacity at the back end is very difficult, either to grow in terms of staffing, whether it's funding challenges or whether it's estates issues. So hence we have the primary care strategy. And if we go to the next slide. So this is just a nice one-liner. Hopefully it conveys what we're trying to do. So our shared vision, so that everyone in Bob has the support they need from primary care, working in a coordinated and integrated health and care system that supports people to stay well. So that's that access element, seeing the right person at the right time, and coordinated care, but also with a preventative focus. And that's just explained there. If we go to the next slide. Thank you. And this slide just explains a little bit more about what we mean about getting to the right person first time. So rather than looking at the challenge, which is in the top half of the slide, if you look in that bottom half, it has some of the concepts that we want to introduce. They're not new, they're things that people have been doing for a while, but it's sort of how we go about doing that. So self-management, big piece on self-management, supporting our communities to stay well and use NHS websites and mechanisms for getting into their GP surgery should they need it. We have a concept called triage, which I think you may be familiar with, which is how we direct you to the right person. So it's using informed triage, and then that initial contact, making sure whether it's face-to-face or virtual, it's with the right professional in a timely way. So if we go to the next slide. So this slide, also another busy slide, this focuses on that team that we hope will surround our individual patients. So this is what we would call an integrated neighbourhood team, and it would consist of all the functions or all the roles that are described around the circle. Now, an integrated neighbourhood team, it could be as big or small as it needs to be. It could involve all the different professionals as required for an individual's care. So if an individual required mental health, there would be a team that would be able to look around that patient and work with the other people within the team that would all come from different professional backgrounds. In doing so, the ambition is that that care of that patient would be more personalised and could be proactive. The integrated neighbourhood teams would largely focus around those with complex care needs. If we move on to the next slide. And this slide talks about that third component around prevention and us understanding our population and what will help them to stay out of healthcare or hospital for as long as possible. So these are things like understanding the long-term conditions, for example, trying to stop people from the more negative behaviours that affect health. So smoking, alcohol, drugs, obesity, etc. That's what we call our primary prevention. And by focusing on those that we know are starting to have those habits, we can then try and affect their behaviour going forward and those health outcomes. If we look at the next slide. So for us to do all that, so that being able to access the professionals you need and to build an integrated neighbourhood team and to work in that preventative space, we need our enablers. And these are, as you'd expect, workforce. And for that to be, it's about recruitment, retention, ongoing training, well-being, making sure that general practice and our other pod areas are good places to work and people want to come and work in these areas and in Bob in general. Many of our GPs now take what they call portfolio careers, so they don't necessarily aspire to being in the surgery 5 days a week, but would happily work 2-3 days and have another work interest as well. So it's about enabling some of those options as well. Resource. When we talk about resource, this isn't necessarily money. So we need to think about our resources differently, and it might be how we work with other providers. So for example, in our integrated neighbourhood team model concept, if we were looking at something like heart failure, part of that resource might be some heart failure nurses that might come from the trust, or it might be a consultant that would be able to input at a local level. Digital and data, really essential. Without that information to help us understand health needs better and tailor that care, we risk not being able to be as proactive and preventative as we would like. And things like being able to have that read-write access into care records is really important as well. So professionals can see what care you've had when quite easily and talk to each other more succinctly. And the final one is our estates. And some of our estate is less than ideal. We need to think about how we work differently. How can we use the buildings we've already got, not just in general practice or in pod, but across our local area, whether that's local authority properties, etc., and just think a little bit differently. If we go to the next slide. Okay, so those three areas that I've just explained, those kind of concepts about seeing the right person and integrated neighbourhood teams and prevention, we've tried to finesse those down to three key deliverables that we'll work on over the next 2-3 years. So the first one here is the non-complex same-day care. So that is a principle where we use our data to inform us about our patients coming through the door, and whether they're complex patients or whether they're usually fit and well and just have an issue on that day. And what we'd be able to do is ideally stream them off, and they can be seen quickly and succinctly. And by doing so, we can then allow time for some of the GPs and for some of the professionals working with them to focus on the more complex patients under the integrated neighbourhood teams. And then the third element is the cardiovascular disease specifically. We've gone for cardiovascular disease because it's been highlighted to us by our colleagues at Health Innovation because of the outcomes we have and the impact of CVD generally, and the fact that we are able to stem that flow if there are a small amount of actions we take up front, things like reducing smoking, helping with obesity, and taking blood pressure and lowering that. So they're the three key areas of delivery. And then I will take you to the next slide. So this slide really is just saying that whilst we're doing all that, we're not going to forget about the other good things that are going on in the system. So over the last year, for general practice, we've been doing a lot of work around what we call PCARP, is primary care access and recovery. It includes increased uptake of the NHS app. It includes improving the primary and secondary care interface, so how primary care and secondary care sort of relate to each other and work with each other. And of course, we'll still continue with some of our workforce initiatives, training, etc. Pharmacies, the same. We've got the rollout of the pharmacy first, which we will continue to do. Optometry in particular, we've got something called REGO, which we will aim to promote a lot more. So this is a referral platform so that you can go straight into the secondary care referral system if you require it for an eye issue. Dental, I think I've already explained a flexible commissioning, but we want to be a little bit more innovative, think about mobile dental units, things like that. And finally, community. There's a big piece of work on direct access to some of our community services, but also for that mental health linkage as well. So is there another slide, Alice? Ah, no. So I've given you a lot of information. I'm happy to take questions. I've got Dan and Rachel who equally would be happy.
The slides down, that would be great, and then people can see. Lovely. So we've got a number of questions in the chat. You might like to start with one of those. Let's just see.
So shall I do the first one? This one, how do you work out the outcomes are good if there is little or no listening to patients? Yeah. So whilst we've been doing the engagement, one of the biggest areas is that our interaction with patients on a number of levels, whether that is about co-production, whether it's about feedback, whether it's about engaging with them and talking to them about the changes. We are clearly not doing enough. So I'd like to say, alongside this piece of work, there will be a focused primary care communication strategy. So we will focus very much on that piece. So we are listening. The outcomes, often, most of our outcomes, we set specific measures. The way that we hope to deliver on some of this change is about small changes at practice level or provider level, and looking at how that impacts on their business and their patients and their patient outcomes, and we will track that. But we don't want to overload with vast numbers of measures. I suspect we'll land on a few key ones that we will then monitor the program with. Is that okay?
So if people want to either put their hands up, or we'll just carry on working through the questions in the chat. So the next question from Barbara was, can you explain in more detail what happens at patients' first point of contact? How will this take place, and who will it be with, and what qualifications will they have?
Yeah, so this will very much depend on the patient and the access routes that we will have. There's no hard and fast rules. What we are doing is providing tools to general practice to choose whether they utilize them or not. Some of those tools include things like the NHS app, which is kind of one specific route in. So if we were to go to a sort of triage model, we would design that with our patients, and those that are more complex would see their GP as they would ordinarily see their GP. It's the ones that are usually fit and well, they may see a different professional, whether that it could be anything from a physician's associate working in a different way, it could be a more junior doctor, and all of this, the actual design of some of this, will be done at place with general practice and patients.
Thank you. So I think you've touched on one of the other questions, which is about how the triage system would work and who it refers to. One person's commented on the stressful workload of GPs. Another person, Sue Wild, can you explain what you mean by finding better ways of using the buildings we already have?
Yeah, so a lot of our estates, sometimes it might not be fit for patients to come through it just because of the design of it. It might be better used by admin, for example. So we've done a piece of work looking at everybody's estate in primary care and looking at what the clinical need of their patients is and how they want to work with colleagues, and thinking through, actually, does this need, what kind of building does this need to be provided in? Are there any local alternatives? It might be things like working with local authority, using some of their estate. There are other new things that are coming out, things like what we call pods, which are distinct units where you can have your blood pressure and your heart rate taken. So there's lots of sort of different things. So I think, again, there's no one size fits all.
And I think I'll lead on to the comment from Sarah James that Dan has responded to, which was similar around the pressures on the estate. And here we're talking about the ongoing Great Western Park in Didcot, which I think has been moving on now. Perhaps Dan, you'd like to just comment quickly on that one.
Yeah, there's no further, I think there's nothing really to, it's a very specific issue to Didcot, and there's agreements in place and the updates there that was updated in February. So that's progressing. Just on the general theme about using estates, I think part of the conversations that I have routinely with city and district councils, with the county council, is we all have a lot of buildings and sometimes they're quite close together to each other. So how can we actually use those buildings in a better way? So finding ways of using estate to deliver different services out of different places. So libraries, community centres, village halls, leisure centres, quite interestingly doing more stuff around things like physio out of leisure centres where there's a gym. Health checks are being done out of leisure centres. We've got the early pregnancy unit that's in Rose Hill Community Centre. So there's lots of good examples. And recently, just last year, we opened an urgent care centre, which is a primary care run service out of the John Radcliffe, just off on their building near to the Manor Surgery. So lots of examples of where we can all come together to use our estate differently, because I think as the resident of Didcot knows, and as many of us know, actually the time and complexity of trying to build brand new GP surgeries means that we actually have to look at alternatives of how we use our space differently.
How about, sorry, excuse me, Sue Wild, how about existing GP surgeries that need upgrading? What are you doing about that? Because I believe there is an issue in some places with funding being available. I have a vested interest. This is for Bicester, and a bit like the comment about Didcot, and the comment that was said about specific to Didcot maybe, but affecting thousands of people, exactly the same is true of Bicester. So thoughts about how you're going to fund the improvements that are needed to some surgeries? How is this being handled?
So we do have funding for what we call minor improvement grants. So they are small kind of scale changes, additions to the current footprint, the estate, which practice will hold. I think what you're probably referring to is where, there's a huge increase in population and the practice needs to grow. There are challenges around the funding, and it's likely that we will need to just exist within our means for some time. And that's why we're thinking about, right, how do we work in a different way, and how will that model of care evolve so that we can fit within what we have. Where we do have huge issues, we do, of course, escalate them, and we have to think right across Bob.
not satisfied, but you're obviously not going to do anything about it. So maybe you'd better move on to another question.
One question that's here from Maggie Winters is around the 4 pillars you mentioned don't include 2 aspects which are of great importance to older people: audiology and chiropody. Why not? And then she gives the example of the lack of the impact of earwax removal and the lack of that support impacting on people's lives. And she can't find any information on the ICB website that directs people to this service. So there's quite a lot on the audiology service. Perhaps you could comment on that and its place in the primary care.
Yeah, so yep, the pod services and general practice are core primary care services. We would consider chiropody and audiology not to be primary care. Some of those elements around earwax, etc., you know, these are things that have been coming and going for a long time. Self-management is where it's at the moment. You know, we have to make some hard decisions sometimes, and at the moment that isn't factored in. We haven't been looking specifically at different conditions within our primary care strategy. It's a vision for the future, so it just focuses on those 4 core pillars that we're responsible for.
Sarah Wild, you've had your hand up for a while. Would you like to ask your question, or is it the comment in the chat?
Okay. The question that I wanted to ask was, why is the Integrated Care Board actually not talking to patient participation groups? Every surgery has to have a PPG, and there is a wealth of concern, information that could be made easily available to the Integrated Care Board if they bothered to contact a PPG. So why isn't this being done? Thank you.
That's helpful, Sarah, and we'll take that back. And I think we do try to engage through our health watches, etc. But you know, if we feel that that's not sufficient, we can look into that.
Could you please look into Vista?
Just to let Sarah knows, we're doing a survey at the moment just to understand a bit more, again, refreshed, as all of these changes have happened from PPGs, and that will help us inform that support that comes to PPGs.
And Veronica, can I
just say, we've asked for somebody from the from Bob to come along, and we were told they won't.
Veronica, can I add? So yeah, one thing. So in the change to the ICB, as we've gone to Bucks, Oxfordshire, and Berkshire West, I think I've heard on a number of occasions at Health and Wellbeing Board and scrutiny and from PPGs that we've lost that contact. Like Veronica says, we're looking. There's a survey gone out to understand how best to re-engage and do that. Having said all of that, and Veronica knows this, and hopefully there's people on this call that know this, I've personally been out and spoken to PPGs. I was at a PPG last week, so I'm not sure, Sue, who said no to you, and there's probably a perfectly good reason why they have said no. But again, given diary constraints and things like that, most of us are willing and able to come out and talk to PPGs, and like Veronica knows, and hopefully some people on the call may have met with me at PPGs in the past, so I'm happy to come out.
Chris, Accord, would you like to ask your question?
Yes, thank you very much. And apologies to the Healthwatch Oxfordshire people who were on the meeting last night, because I'm going to repeat something of what I said last night. It also picks up on what Sue Wild has been saying. You've made great stock that we're going to have to find different ways of doing things. We're going to have to continue on as we are in terms of estate, for example. But I think it's fundamental that patients and the public have the right to expect good GP premises and facilities. not ones that are creaking at the seams and are basically out of date. Unfortunately, when it comes to GP practice updates, buildings in particular, it seems the funding model is broken. And I don't think we're hearing enough about this. Now, it is becoming an issue, a national issue. Those who subscribe to Health Service Journal would have seen a piece that they wrote, I think about 10 days ago, which I thought was excellent, and highlighted for the first time in a national arena the real difficulties that we have here. And this is never exemplified better by what happened in Bicester between the years of 2019 and last year, exactly a year ago, in fact, when effectively the Health Hub project that we had all been banking on to deal with the population increase was effectively cancelled by the ICB because of a funding impasse. A funding impasse that is still there, and a funding impasse that, according to the Health Service Journal, is now a national issue. And it was interesting to see that some ICBs are coming out, being honest with the public and patients and talking about this. Coventry and Warwickshire, for example, was highlighting this. And I would like Bob to do more of this, come out and talk about it. In terms of the Bicester project, ICB said virtually nothing. It was left to us all on a local level, including Sue Wild, to do the media work and communications work. And here I hold my hand up. I was one of those doing the communications work on this project for the 2 GP practices that were placing great stock on moving to the new Health Hub, Montgomery House Surgery in Bicester and Oxfordshire Medical Group, combined, nearly 40,000 patients now. We're exactly in the position where we were 5 years ago, with huge housing development in the pipeline, thousands of people coming to our location, and we don't know how they're going to be able to register if this continues without giving us more capacity in this type of facility. So while I accept that, the communication, that we have to do things in the community differently, there is real problem in the GP practices. And I'm sure this isn't just Oxfordshire. I'm sure that the other counties are experiencing this too. But I would like ICB to say more on this. And I wondered if you've got any comments this evening at this meeting for us, please.
So Dan, I think you're going to respond.
I'll probably not be able to give a huge amount of detail on the Bicester one specifically, but Chris, you're right. The funding model and the challenge of finding ways of building and improving estate is difficult. Partly it's difficult because of the capital regime that we have in the NHS. So we're under quite a strict regime from the Department of Health, and we have a limit that's set that we cannot go beyond, and that comes down from Secretary of State. And most of our capital has to go into the acute hospitals, into mental health hospitals, into community hospitals, into GP practices, and for buying all of your equipment. So the kind of one-off costs of equipment and things like that. So that's one thing. Our capital regime is a challenge. You combine that with high interest rates, the high cost of construction, it's really difficult to see how we can deliver all of this stuff. And I would say, Chris, it's not just primary care here. Bear in mind, nationally, I think the current backlog maintenance bill, that's just to mend our acute hospitals, been recorded at about £9 billion. So that's before we start building any of the new hospitals that we've been promised. So there is an issue with it. Now on the Bicester and places like that, where we can't deliver and build new centres, they are looking at different ways of doing it. And I think there are plans in place to do it. But that's why I do say, and I saw one of the questions about this is a workforce problem. It's really not just a workforce problem. This is a model of care. How do we deliver a new model of care for a changing need? How do we deliver? People are living much longer with more complex needs, lots of illnesses altogether. How can we support people in their homes? What role does digital care play in that? And I know digital care isn't for everyone, but for those people where it does work, then I think there's real opportunities to make that. What other contributions are there to people's health and things like that? So we do have to think about this in a holistic way. And Chris, I appreciate, and everyone in Bicester and other places that have seen those kind of projects fail, I understand the frustration, but we are trying really hard to find alternatives, because it is, like you say, a really, really challenging environment to work in.
Thank you very much. Thanks for letting me raise it. And I would just repeat, if you could perhaps say something on an ICB level that would help the national awareness raising of the situation we're facing here, it might be very helpful for a lot of people.
Thank you, Chris. So if we'd like to come to Sarah James. If you'd like to ask your question, Sarah, you've got your hand up. Okay, we'll move on to Geraldine Coggins.
Thank you. Yes, I've unmuted. I am concerned about what you've been saying, which is, I think, disguising the fact that there isn't enough money. And we all need to be quite cross that there isn't enough money in the NHS, and we shouldn't be shy about saying it loudly. Apart from that, there's a problem with workforce and recruitment. And I did mention in the chat that I know that young GP trainees are being advised, certainly in Oxfordshire and probably around the country, that when they fully qualify, they should not take a full-time job because the job is too stressful. What a waste of training that is. Why not make the job easier to do, less paperwork or whatever it is that causes the problems, so that we actually have more staff? Because what you seem to be doing and talking about in the ICB is covering up for the fact that resources are very limited, and the most important resource is the workforce.
You want me to come in? Geraldine, I hope you don't think we are covering up for those things. I think we've been fairly overt in our, some of our supporting documents that go with the strategy. What we do know is things that do need to change, and workforce is one of them. My colleague Rachael, you might want to come in, Rachael. She does a lot with our workforce to try and retain them in our area and to look at that developmental pathway. I think maybe what we do recognize is that partnership model and the importance of that and the need to attract people into that. Sometimes that might mean that they may not want to work sort of that what we would call full time. They might want to do other things, but I think as long as we can leave that open and that becomes their choice, we want to make primary care an attractive place to work, and so that's partly why we're out talking to so many people, including the GPs, to see what that looks like. Rachael, I don't know if you want to say a few things.
Yeah, I would just sort of supplement that a little bit. So last year, the long-term NHS workforce plan was produced. It's the first time we've ever had anything like that. That does talk about training significantly more staff, but obviously there's a lead-in time to that. It's going to take a number of years for those staff to actually be in the workforce. So what we're trying to do in the ICB is to put into some initiatives to support the staff we've already got. There is nationally a shortage, so we need to really look after those ones we've got. And sometimes that does mean that they do work part-time. And that's better than them leaving the health service altogether. So we are doing a number of things to support our staff on the ground.
But they shouldn't have the sort of job that means that they need to work part-time. I'm talking about young GPs. Of course, as they get more qualified or more experienced, they may well want to work part-time, and they may well get involved in medical education. But when they're newly qualified GPs, they should be able to work at least 4 days a week, but they're not.
No, many aren't. Yeah, absolutely.
Okay, thank you, Geraldine. I'll just pick up on Sarah James, because you had your hand up and you didn't come into the room. But would you like to ask your question, Sarah?
I don't think you can hear me.
We can hear you.
Oh, you can? Okay. Because I couldn't get my microphone on very quickly, and then it sounded like you couldn't hear me. I had just put it in the chat. It was, I mean, it's very related to what you've been asked already about, is there sufficient resource for the population growth we've seen? So I'm a councillor in Vale of Whitehall district, and there's been 14% population growth in 10 years to the last census. And there's no sign that our healthcare is keeping up with that at all. And certainly in my own ward, I know there's really acute problems for people who are on the east side of the ward, whose catchment area is Didcot. And, you know, they've been told they can't, when they've moved into new houses, they can't register.
So I don't have an update for you, Sarah.
But do we have the resources? I mean, have our resources in Vale of Whitehall gone up by 14% to cope with the population? I mean, that's not even particularly an ageing population, I wouldn't say, in Vale of Whitehall. I mean, we do have, obviously, overall an ageing population, but a lot of that new housing growth around Didcot and Wantage and Grove has been younger families.
I guess Sarah, when you talk about, are you talking about specifically general practice and primary care? So GPs, opticians and dentists?
Yeah.
Right, yeah. So so again, as far as I know, we have a plan to deliver services, and we set that out, and that plan, and there's a cap, something called, for GPs particularly, you get a capitated budget based on practice size and things like that. So as far as I know, we plan to have the capacity to meet the needs of the population. It's the same as the work that we do every year in our annual planning cycle to look at how we're going to meet the demands in acute care, mental health, community services, against the various targets. So you'll have heard about 18 weeks targets and things like that. What you do see and what we do know is the waiting list and backlog for some of that stuff is growing. So it's increasingly challenging to meet the needs within the certain timeframes and expectations that are set for us.
Thank you. Jennifer, would you like to ask your question?
Yes, there were 2 points that I'd like to make, please. One of which is, in your slide, you spoke about GPs and I presume other clinical staff spending large proportion of time on administration between services. It seems to me if we have a shortage of staff, which we most obviously do, we should be ensuring that the particular skills that they're trained for are maximised. Do you have any, realistic strategies, not concepts or plans or whatever, a realistic thing of how that could be done? Because one of the things that I keep getting feelings here is there's a bureaucracy and a bureaucracy and a bureaucracy, and I recognise the slides and all the rest of it. But I feel a real frustration of this is something that all practices will benefit from. And my sub-question is, you mentioned that the dissatisfaction with making appointments, the level had gone down by 19%. What is the level of satisfaction of people making appointments? Thank you.
Shall I come in on some of the, I think there's two things around the bureaucracy one. I'll leave the satisfaction to colleagues. So I do think actually primary care and GPs in particular are some of the most innovative parts of our systems. So they do have a lot of digital technology and things that enable them to be more efficient and effective. So enabling their workflow processes to work. So and that's up to the practices. So they had the admin services and systems that they bring in to do that. So I think that's one thing. And then just on the point about, are we over bureaucratic and things like that? For good or for bad, we have a huge amount of a large regulatory framework that we have to meet, whether it's Royal Colleges, CQC, regulators and the like. And I think a lot of it is in place for safety. Wherever we can, we look to reduce and streamline it. And we are doing a lot of work, and hopefully, and I don't know if people are aware, but the integrated care board itself is reducing its running costs by close to 30% over the next 2 years. So that will result in a reduction in some of the kind of bureaucracy that you see.
So just to continue from that, so I mentioned in the presentation this primary and secondary care interface. That's where we have a lot of our challenge around paperwork, things, pinballing between different providers. We've got a particular program of work on that to help improve. And what's worked in Berkshire West is to have almost what they call an interface manager who supports them working through some of those issues, just to try and smooth things through, reduce that bureaucracy. And and I think if I go on to some of the other interventions, digitizing the records, but also that kind of referral routes in so that it's electronic, things like that. Part of the work is about discharge notes from secondary care and fit notes as well. So that would take that from primary care providers. And also some of these pathways as well. So self-referral into specific services as patients. So then you don't come via the GP. The GP doesn't have to do that referral form and see and be that in between party. So there are different things to try and focus on that. I think it's the speed at which we can change things, because we are changing a big machine and it takes time.
Thank you.
Your other question, sorry, was on satisfaction. What is satisfaction? And yeah, that's a really good question. In the surveys, it's I'm not satisfied, I am satisfied, those sorts of things, and we measure the percentage. What we try to do is we look at the themes and the trends and see if it's going up or if it's going down. What might satisfy one person won't satisfy another, so we have to bear that in mind. So it's not as easy as those initial results that we see.
And James has just helpfully put in a link to the survey results in the chat.
Great.
Oh, fabulous. Thank you.
So we've just got a few more minutes. I think we could just take one more question from Stuart, and then we will start wrapping up.
Hello, thank you. Can I take you down from the heights of proactive enabling and integration and triage and so on, and suggest that what many people want, many patients anyway, it's just very basic medical assistance. To think of earwax removal as being a work in progress, for goodness sake, it causes massive agony to a large number of people, and it really doesn't take much sense to work out a solution. And the same with ingrown toenails and whatever. Dentistry in my area, and it's a fairly well-off area, is down at the local pub, where we get the victim drunk and we pull his tooth out. That's the level of sophistication at which most people work. And the level that you're on is proactive enabling with triage. It's some different world, I think.
Right. So no, Maggie, I think we haven't got time for one more question, if that's okay. I think if there are further questions, we can email them. Would you like, you can either put your comments and suggestions into the Integrated Care Board portal, where they're asking for feedback and comments on the primary care strategy. That's in the chat here.
Veronica, we have extended that engagement, the survey, till Sunday.
Okay, so that's been extended now till Sunday. So you've got till Sunday to leave.
I'll put the details on there. You should be able to see it on Your Voice, Bob. It's under, and there is a survey there. Thanks.
And likewise, I'm if you want to email me at Healthwatch with your further questions, I can pass them on to the appropriate person. So would you like to make some concluding remarks about the next stages with this strategy and where it goes now?
Yeah, I'm happy to. So the engagement portal will close on Sunday, and we will gather those the feedback together. We'll be looking at themes, and we'll be looking at actually how that may impact the strategy going forward, and there might be some adaptations to that strategy. We'll then take that strategy to our ICB board for ratification, so that it's approved, and that's expected May time. And after that, we do the very challenging job of action planning around some of those key themes, and getting interested parties. So there might be opportunities to get involved, and we need to work this up with our comms colleagues, how that we might communicate that to you.
Great. I mean, I absolutely essential, isn't it? The patient engagement beyond,
Yeah.
and carrying on through this process. So,
and there'll be different ways to do that as well.
Good. So I think with that, we will thank our speakers, Dan, Louise and Rachel as well, for your contributions. And we'll please, as was said, put your comments into the survey open till Sunday. The link is on here. The link is on the Integrated Care Board engagement website, and you can also find it on Healthwatch Oxfordshire news and website as well. So with that, we will close this. For those of you who might have arrived late, the recording of this will be available on our website, Healthwatch Oxfordshire website, probably on Monday, I think, at this stage. So thank you very much, and we will say goodbye and close the meeting now.
Thank you for having us.
Thanks,
Bye.
everyone.